a digital initiative of Health and You Therapeutics, a joint venture with New Link Company Limited, Japan. Health and You is a company having a vision to fulfill unmet medical needs. Unmet medical needs by launching new, innovative and differentiated products. We were the first in India to launch amitriptyline plus mecobalamin combination for diabetic neuropathy and migraine, Amnurite. We also have 5 milligram strength in this, Amnurite 5, 10 and 25. We are the only one who are importing mecobalamin injection from Japan to give you highest quality and 100% mecobalamin when you inject. We are the first one to combine amitriptyline plus propranolol SR for migraine when one drug is not enough. Amnurite beta 520 ER and 1040 ER. We were the first one to combine pregabalin in a sustained release form to match pharmacokinetic profile of amitriptyline, Amnurite P. It is pharmacological for severe neuropathic pain. We are also the first one to give you a 2.5 milligram strength of clobazam to add flexibility and add control in your epilepsy treatment. So we have Adclobaz 2.5, Adclobaz 5 and Adclobaz 10. In near future, we will be launching a vitamin therapy for migraine recommended by AN. And many more drugs with your suggestions and with your recommendation, we will launch for the first time in India to fulfill unmet medical needs. Today we have part 3 of this webinar put together by Dr. Rohidas. And this is a truly international webinar because we have an international speaker attending our webinar today, and he will be talking to you. So I hand over the session now to Dr. Nilesh, who will coordinate this session. Dr. Nilesh is a neurosurgeon from Mumbai, and he heads Neurosciences Center in Vedanta Hospital in Thane, and he has special interest in endoscopic surgery. So over to you, Dr. Nilesh. Thank you very much.
I wish, are you able to hear me?
Yes, we can.
I wish you a very warm good afternoon to all of you who are joined for today's international webinar on endoscopic spine surgery. Today we are covering the anterior and posterior cervical endoscopic approach for discectomy and cord decompression. It's my honor to introduce Dr. Professor Joachim Oertel, who is the Director of Department of Neurosciences in CERN, Germany, and he is also pioneer of EasyGo system for endoscopy. Then I will introduce. It's my pleasure to introduce Dr. Rohidas, a well-known endoscopic neurosurgeon from Kolhapur, and he is also pioneer in India endoscopic spine surgery with Destandau technique. He started Destandau technique in India 20 years back. Then Dr. Mohinder Kaushal, a well-known spine, knee and sports surgeon from Chandigarh. He has a vast experience of 18 years in spine endoscopy surgery and expert in doing minimal invasive spine surgeries. Dr. P.C. Deck, he is today's moderator. He is a director of orthopedic care hospital in Bhubaneswar and an expert in minimal invasive spine surgery, and he is also honorary secretary to WESS. And now I'm going to hand over this session to Dr. Rohidas, who will give a brief introduction of Dr. Oertel, and he will continue the next session. Yeah, we'll hand over to Dr. Rohidas, sir.
Good morning. I welcome Dr. Oertel for this webinar on cervical endoscopic approaches. He is the pioneer of the EasyGo system, and he is one of the neurosurgeon who is well known in spine endoscopy and neuroendoscopy both. I met him in 2008 when he had conducted workshop at Germany. So without wasting time, I will request Dr. Oertel to start with his presentation.
Thank you. Let's see. So you see my presentation now?
Yes, it's clear.
Okay. Yeah, good morning, everybody. Audio is fine. So I was talked to speak about cervical application of the EasyGo system and briefly introduce the history of neuroendoscopy.
May I request everybody to unmute the...
Yeah, much better. Thank you. And I will, the first third maybe is about the history of neuroendoscopy, and the second 2/3 are about the cervical spine and the endoscopic application in the cervical spine. And it's a distinct pleasure for me to be back in India, although it's not, it's just virtual, but, it's a difficult time. So we have a lot of changes, and I'm sure you have a lot of changes during this difficult time. So I have patents with Storz company. It's about EasyGo and 3D imaging. I used to act as a consultant to Storz company, but it opens whether they will continue to do research on endoscopic applications in neuro and spine. So right now we are negotiating if this is going to be continued or not. This is Europe here, and this is where I'm from here. It's very close to France border. So we see that this is Grande. This is the area in France where most of the COVID patients actually live. So this is we are 10 kilometers from France border. So it's a very difficult time and difficult place. A lot of exposure of this difficult virus. You see here, it's a 1-hour drive from Frankfurt Airport, which is well, almost not working right now. Luxembourg, 1-hour drive, and Strasbourg is here. So it's 1-hour drive from these three major cities. The department, it's about 90 beds and 20 neurosurgical ICU and 70 to 74 regular. We do like 300 to 400 endoscopic procedures per year. This is the department here, and this is University Campus and of the University of Saarland. Well, it's a very traditional department for spine. There's still a fight going on whether Dr. Kasper and Dr. Löw performed the first microdiscectomy in this department, or it was Yeşilgöl. It's not really unclear. It's almost similar. It's not really clear. It must be almost simultaneous. And the Kasper used to work here in this cervical system, and this MIS systems were developed in this place. Now I want to come to the history of endoscopy. It's just a brief history, but it's a very impressive history if you are not aware of this. One of the first endoscopes, or the first endoscopic idea, was made by Filippo Bottini, who was an Italian stemming physician, very close to this area. It's a 1-hour drive from Mainz, where I used to work before. It was in 1773 he was born. And in 1804, he developed a speculum with a candlelight source called lichtlight, a light conductor. You see, this is the idea from his drawings. So it's basically a candle, and you use a speculum for to use it in open spaces like in gynecology, urology, and so on. He used 2 tubes for light and image transport. So it's one for the candle and one for the view. And it looked like this. This is a replica. I don't know exactly how you... Can you see this? Can anybody give me any feedback about the video? Is it okay or not?
Yeah, it is okay, sir. We can see it.
Okay, thank you, thank you. This is the replica from the Nietzsche-Leiter Museum from Vienna. They were so nice to give this to us for a couple of days. You see that this is the technique. You see a speculum, and you see 2 chambers, one for the light and one for the view. I will forward a little bit. And this is the idea here. There's a small optical lens. And then his idea was to introduce this into any open space in gynecology, urology, and so on. Actually, he reported this in the small Frankfurt local newspaper, so it was not very well noticed. Then 2 years later, he presented to a small group of physicians in another German city, and later in Vienna, in Austria, to the Military Academy Josephinum. And in Josephinum, when he presented it there was a lot of critics. It was considered to be impracticable. And 3 years later, Bozzini died before really a clinical application of the Lichtleiter was done on typhus. However, in 1806, when he presented this to the Military Academy Josephinum in Vienna, the prosecutor of Academy of Vienna, Johann Georg Ilk, he developed an own version. So 2 months later, he brought an own version to the scientific community in Vienna, and he thought that this might be a better version. So even 200 years ago, there was some difficulty and fight between the scientists. And you see here, this Viennese model of the Bozzini Lichtleiter was also never brought to the market. However, the first time the name an endoscope was used was done by Desormeaux. Desormeaux developed an endoscope with an external light source with a gas oil, so no candle anymore, and a single optical canal. So this is here. There's no, there's only one replica here available in the Lichtleiter Museum. Then, very shortly after this, in late 1800, you see here that Maximilian Karl Friedrich Nitze developed the Nitze-Leichter cystoscope. And this looks almost like a cystoscope today. It was an electrical light source, a lens system, and improved illumination because of the lens system. So it's also a German physician. He worked in Berlin, Dresden, and Vienna. You see here, this is the principle, different lenses, and then an electrical light source. This is one of his Nitze-Leichter cystoscopes, and you see this is actually original. It's not a replica like in the other case. It's an original cystoscope which was used in the late 1800 and early 1900. It looks pretty much like an endoscope today. However, the optical system was not as good as it is today. And the first endoscope with a calculated optical system, so that means that they really calculated the lenses, the position of the lenses, the fragmentation of the lenses and everything, was introduced by Ringler, Wolf, and Zeiss. And this is it's the Wolf company, which now is with the RivoSpine, one of the market leaders in endoscopic spine surgery. And I think the next major step was the introduction of the Hopkins rod lens optical systems. The difference was that now you don't have a small lens with a lot of air in between. Now you have a long lens and only is minimum space with air. So you have a much better light conduction. And then after having these techniques, this is the Hopkins optics, which is still basically available in use today. The other part was the introduction of a new camera system. And that was in the 1975, there was the introduction of the microchip technology. And now these days we know that we have a 3D chips, we have a HD resolution, we have 4K resolution now. So I think a lot of this improvement is now in the camera area. So the further developments of the techniques in neurosurgery, introduction of the cold light source here by Karl Storz, led to a renaissance of the endoscopic technique. And in 1991, Bauer and Helwig coined the name minimally invasive neurosurgery, which is actually endoscopic neurosurgery. It was published in the Neurosurgical Reviews in 91. So when we talk about indication for endoscopy, we can have a lot of indications in neuro, But we have now an emerging field for the last 10 years is spine, and particularly we'll focus today on the spine cervical application. When we talk about endoscopic techniques, there are particular qualities in spine, particularly in the cervical spine, we have to address. Well, we have a better illumination. We have a much better focus on spot. We can use angled optics, which I think is in most of the applications in spine not that important, but there are some where you can really use endoscopic angled optics and provide superior results. But the most important thing is we try to use the endoscope to be less invasive, to minimize the approach, and to be less traumatic by the approach. So we have no preformed cavities, except for thoracic. Thoracic is different. I'm in favor of the thoracic endoscopic approach if you have to do any thoracic spine procedures. But this is a different topic. Here we talk about no preformed cavity in the cervical. We have very good results with microsurgery, and we need sufficient decompression of neural structures. So we have to find our way with a particular technique how to minimize the trauma of the approach, with maximize the decompression of the neural structures and maximize and achieve optimum results at the area of compression. Theoretical advantages are we have minimal muscular trauma. We might have decreased scarring because we have not that much exposure of the spinal canal, minimum exposure of the dura, minimum exposure of the nerve root. There's a significant patient demand, and I minimum have 20 to 30 cases per week, just asking in my outpatient clinic for an endoscopic procedure. And we want to achieve superior cosmetic results and less postoperative pain. The problem is all the techniques are different from the open microsurgical technique. The tight selection of surgical candidates is required in many techniques, and we need a prolonged learning curve. The learning curve might depend on the system, the selection of candidates might depend on the system, but overall we have to have some training with these techniques before we can really achieve the good results and excellent results with the endoscopic cervical spine. Often a higher recurrence and nerve injury rate is reported. Well, in our personal experience, we don't agree with this. We don't have a higher rate of recurrences. We don't have a higher rate of nerve injuries. But what we have in the beginning, if you're not familiar with the technique, you have a higher risk of incomplete, insufficient decompression because of the high magnification and the less good overview than compared with wide open surgical approaches. Well, this is an example of the EasyGo system. This is the old system. And now I will come to the cervical spine, the peculiarities of the cervical spine, how to approach the cervical spine. There are two options. One is from anterior. So if you want to evacuate really all the disc space, then you cannot pass the spinal cord. You have to come from anterior to really do a complete discectomy, like in any arthroplasty, like in any severe cervical stenosis. I think it's mandatory to come from, if the compression is from anterior, is almost mandatory to come from anterior to really sufficiently decompress the spinal canal. The options for posterior are, if you have a posterior compression, you can do laminectomy or interlaminectomy. If you have a lateral or mediolateral or interfemoral stenosis, like a stenosis from posterior, like a disc prolapse from anterior, and you can pass easily without risk the spinal cord, then this is also a good option for posterior approach. I will start with the posterior approach because in my opinion, this is the most significant. Okay, this is the most significant difference compared with the open technique. The positioning, we use it, it's identical to microsurgery. We try to put the patient in a prone position. It's actually easier to use the semi-sitting position because you have less pressure on the veins, less congestion of the veins, but you have to have some experience if you really want to do it in semi-sitting. We started with semi-sitting in the cervical approaches, but this was when I was back in Hanover with Professor Sami's department. So we had basically 2, 3, 4 sitting cases every day. And now here in Hamburg, we have, well, maybe 1 case per day. And we have changing anesthesiologists all the time. So I'm not that sure that we would really immediately notice any embolism problem. So this is why I prefer the prone position now. The prone position is less risky from this perspective, but it's more demanding for the surgical decompression because you have more to deal with the epidural veins. Then after the positioning of the patients, we always try to position the patient with a heart level. The surgical field should be above heart level to minimize congestion. And then we identify the disc level. This is another thing which might be difficult if you have an obese patient. Then it might be difficult to localize C6, 7. And then this is difficult to perform an endoscopic approach. So in these cases, actually what we do, we have intraoperative CAT scan. So then we do intraoperative CAT scan to confirm the level, or we use neuronavigation and the cervical spine. If you don't have these options, just by counting the lamina, probably it's very difficult to perform an endoscopic approach. Then we do small paramedian skin incision, only puncture the muscle fascia and insert the worksheets with the dilators. This is the positioning here. You see the head is rather high above the heart level. This is not possible in many patients. And I will show you the video. It's very, very important, in my opinion, to have a Mayfield 3-pin head holder to really fix everything. Everything should be stable, and then you have to localize the level. This is a case, a typical case. You can only see down to C5, but here we wanted to approach 5, 6, 6, 7, left side. So 5, 6 is no problem, and then if you address the adjacent level, it's easy to localize the adjacent level. Skin incision is in a paramedian, then you puncture the fascia. This is puncture of the fascia, and then you introduce the dilators. Well, if you have a case with prior surgery, probably I think it's not a good case in the cervical spine to continue with an endoscopic approach, at least not if it's the same side and the same level, because then you have a risk that there might be bony fenestration, and you could harm the spinal cord. So you dilate the muscles, and this is the key issue. You really have to thoroughly dilate the muscles and then introduce the worksheet. What does it look like if you work then? It's a bimanual surgical technique. You see it here, next video. This is the bimanual surgical technique. We work under air, not underwater. And then we can use a suction and bipolar, and the screen is on the opposite side. What are the indications? This is an indication here. This patient had a facet fracture on this side. You see here the fracture facet and the C6-7, and he had triceps, no other deficits. And this is what we did. There was actually a snowboard injury. We did very thin patients, an optimum for an endoscopic approach, localization of the level, and then identification of the level and the step-by-step surgery. So we do paramedian skin incision about 1 centimeter length, go in with the dilators, You have to pay attention that your tube is really at the level of the facet of the lamina, that you don't have too much connective tissue in between. Then you introduce the scopes, and then you can work with a bimanual technique. This is the intraoperative view. You see here the identification of the ligament. Then you go lateral from the ligament, and you identify here the nerve root and remove the fragment. And here we use the fibrin gel foam implant Tacloseal to have a hemostasis. Another video. For orientation, the upper part is medial, lower part is lateral. I will forward a little bit. In these cases, we use always diamond burr, since you want to have a minimum opening. I think it's not possible to perform these foraminotomies without diamond burr. And you see here, this is the ligament now, and then we go lateral. Just focus at the area of the nerve root, of the foramen, and we go always from medial to lateral. We do drilling first, that we have exposed everything when we have the risk of having to deal with a venous bleeding. Just for magnification, this suction device here is a 2.3 millimeter diameter. So the opening here might be 4 by 4 millimeters, so very small opening. Then you use the hook again to identify the neuroforamen and the nerve root, and then you go lateral. Here you see now the fragment. You see the fragment here. This has to be removed, and then you see underneath the fragment is the nerve root. Yeah. Then you have to see that everything is decompressed lateral, that you really, the root is completely decompressed 360 degrees. Another indication we use frequently is if it's not fracture facet joint, unilateral facet is quite rare, is a degenerative stenosis. Degenerative stenosis, we have quite a number, particularly neuroforaminal stenosis, when they have localized neuroforaminal stenosis, 1 or 2 levels. Unilateral is optimum, bilateral is possible. Then we do the compression, as you see here, very localized compression, small opening, and then we decompress the nerve root in this unilateral stenosis. Here you see the facet is about maybe 1/3, half of the facet is preserved, and this is just a very focused opening to decompress the nerve root for neuroforaminal stenosis. Lateral disc prolapse, I will forward a little bit here. Right. Oh, this is from a paper on the word neurosurgery. You can easily look it up. How can I do this now without, this is it, okay, yeah. Sorry about this, now I'm back. This is the second part. I just want to show you the second part with the disc here. This is the orientation, medial, lateral, cranial, caudal. You see here, this is the thecal sac. This is the disc prolapse. You can take out a really quite a big disc prolapse, even through this small opening. Again, for the just to get the idea, what is the size? this suction device is always the same suction. It's about 2.3 millimeters in diameter. And this is a big disc prolapse here. It depends if they are not covered by the ligament, then it's easy to take them out. Sometimes you have to open up the ligament to get a nice piece. But here, this is a optimal case. Yeah, this is very unusual for cervical disc, such a high, big disc prolapse. You see that now there is problem with the veins, so you really have to be sure that you're at the end, you have decompressed everything. Here you see the nerve root. Okay. And this is a typical situation, and now we put in some gel foam, and since it's a venous bleeding, there's not much pressure on it. Okay, so how do we approach the patients from anterior? Well, we use a technique which is identical to microsurgical technique: superimposition, radiological identification of the level, small skin incision, small open approach down to the disc. Well, the technique we use it is basically that we do a small skin incision, and then we introduce the finger, and we go down to the level, and then under view we introduce the K-wire. And as soon as you have the K-wire in place, you just use the dilators to insert the worksheet. Now, orientation: this is cranial, this is caudal, this is left, this is right. Opening up of the disc with a knife, with a blade. We cannot use Caspar retraction in these cases. So if you have a really very, very narrow anterior disc space, then I think it's not a good candidate for an endoscopic approach. But as long as the disc height is more or less maintained, you don't need a lot of destruction and repositioning, then I think endoscopic approach is feasible. Again, you see the high magnification. Step-by-step evacuation of the disc space. This is now under 25 degrees vision. There was a left-sided disc prolapse. Then diamond burr to do the oncoforaminectomy, to decompress the nerve root and relieve the nerve root underneath. It's more difficult than in the posterior cases to get adjusted to use the endoscope. There's the disc. This is the disc prolapse here. You see it? It's coming out here. Because the surgical field, the depth of the surgical field and the tip of the camera is outside this, in front of the anterior surface of the vertebral body. So you, it's a little bit, you need more training to really get the feeling how deep the surgical field is. Then step-by-step discectomy. Kerrison punch and hook knife. Manipulation is a little bit more difficult, I would say, than with a standard microsurgical approach, because you don't have the destruction of the vertebral body. And then at the end, we put under open view, we put a small cage in here. So this is how we do it. It's about 2 centimeter skin incision. And now I go back to the cervical posterior, only bony stenosis. This is the one we really have clearly evaluated over the years. And these are data from 2 papers from World Neurosurgery published in the last 2 years. You can look this up if you want to. You see, we have analyzed 40 patients, mainly it's about 2/3 male, 1/3 female. In the majority, we did single level surgery, 10 2-level, 1 3-level, and 4 we had bilateral. So most of these cases were unilateral single level. This is the surgical time. The average time of surgery is 91 minutes, and time per level is 75 minutes. Preoperative pain in 1 segment was present in 60%, and in 2 segments about in 22%. And postoperative, and this is the most important thing, the immediate pain relief was there in 95% of all cases. Postoperative paresis improved in 2/3. There was no improvement in about 15%, and there was a reduction in 20%. So it's about 85% improved with postoperative paresis, up to no paresis anymore. There was immediate pain relief in 95% of all cases, no intraoperative complications so far. We had no CSF leak, no root injury or new paresis. There was 1 case in a disc prolapse. We had to do, he developed a worsening of his paresis for transient about 4 to 6 weeks. Then the paresis was gone. So I consider this to be caused by the manipulation of the nerve root. There was 1 revision surgery 2 days after surgery for postoperative bleeding, which was about maybe 5 cc. Very, very small postoperative bleeding, but it caused a lot of pain. So we went in, evacuated the hematoma, which was very small, and the patient was fine. In 1 case, we had to abandon the technique because the optical lens was broken. And to conclude, EasyGo system is an accurate and reliable and good technique for endoscopic surgery in the spine, in the cervical spine. The results are, well, comparable or even better than microsurgery, but of course you do some selection of candidates. Although if you're not aware that there are firm selection criteria, but still you select good candidates with just because the patient comes to ask for endoscopic approaches. There's a distinct bias to these cases compared with other cases we do. Well, we have a safe technique. It's no significant intraoperative problems. We have minimal muscle trauma, and most of these patients, they go home 1 or 2 days after surgery, so very moderate, particularly in the posterior approach. I think a significant difference to the open technique, and these cosmetic results are very favorable. With the even in the maximum approach, when we use the green trocar, we have a 1.8 to 2 centimeter skin incision, and the regular approach is 1 to 1.2 centimeter skin incision. But there's a learning curve, so you have to be familiar first with the microsurgical technique. You have to know the technique, and second, you have to know the endoscope. So when you are firm in both techniques, then I think it's a very steep learning curve. You need maybe 4 or 5 cases. You have no problem to adjust to the technique. But if you're not experienced, you cannot do these cases microsurgically, then you will not be able to do these cases endoscopically. And I'm sure that the digital imaging will change the future. I'm sure that the microscope we have it now will not be there in 20 years from now. It will be a digital image. You see, I thank you for listening. I thank Dr. Schokonai and Mrs. Zenger. They went to the Nitzeleiter Museum in Vienna and collected the artifacts. And I thank Eskelab Storz and Richard Wolf for giving us the artifacts and the images. And I thank Mr. Tiber here, who collected all this history as specimen and artifacts. And I think those colleagues from my department who collected all the data over the years. And I think, well, we still have the endoscopy week, but I think most likely we will decide next month. Most likely we will have to postpone it for a year. So maybe we meet next year then in Hamburg, Germany. Thank you for listening. I'm open to your questions.
Thank you, Dr. Oertel. This is a fine, I think, the best example of that endoscopic spine surgery, which is a epitome now of the MISS technique. And I think this is the latest technology where we are approaching to the cervical spine, both anterior and posterior. I think both the demonstration of cervical, of anterior and posterior was very nice. Now I welcome Dr. Rohidas to present his.
Are there any questions to Oertel at present?
A question, Dr. Oertel.
No question.
Yeah, this is sorry. Can
yeah,
I have a
go ahead? Go ahead.
Yeah. They say you have shown here that in your presentation there was a very small bleeding, only 5 ml something, that was creating a problem, and therefore that you did the revision surgery. So what are the precautions you are now taking to stop bleeding per op?
Well, you need a very meticulous hemostasis. If you do a very meticulous hemostasis, then I think there's not a big risk. If you have any doubt, even if you have like 2-3 cc's bleeding, if you have any doubt, I would put in a drain actually. I don't hesitate to put in a drain if I have any doubt. And then also we use gel foam, we use some Tacosil if there's any problem. So you need really 100% hemostasis. Then I think there's very small risk, but it's not zero.
So how many percentage of cases you are putting the drain nowadays?
I don't know, maybe 10%.
Only 10%, right?
Yeah, not that many. Maybe 10%. I don't know, not that many. But it's not really rare. We put in drain.
And for the anterior approach after the discectomy and all, are you doing any fixation? Or any you are using any bone graft?
We put in a cage. Let me go back maybe. Let me see. We put in a cage, but it's a very small cage, and it's available by different companies. So it has to be that small that it really fits through the small channel. So right now we use the Cervifix from Ulrich company. I will show you the image here. Let me see. Do you see it? You see my slide?
Yes.
Here, you see there's the cage inside. You see it?
Yes. Is a cage inside, okay, yeah.
Maybe I can make it larger.
It's
Here,
better
you see?
now. It's better now, yes.
Yeah.
It is clear now.
Okay.
So multiple level also, if you are approaching the anterior approach to 2 level, then also you are putting the same cage, or you are putting the plate in association with that?
Well, actually we have not done multiple level from anterior. We have only do endoscopic assisted. We have done microsurgically with Casper screws. if it's multiple level. We have only done single level so far from anterior.
So it's a standard that more than 2 level we are approaching from the posterior. You are also following the same principle?
Yeah, we do. If we do multiple level endoscopic, we come from posterior. We don't from posterior. We just we do decompression. We have not done cases with additional fusion. So the MI is like endoscopic decompression, cage implantation, then fusion. We have done only for TLIF in lumbar so far. In cervical, not. Cervical only cage, no screws, no plating.
Nice.
Okay. If
Dr.
we
Nilesh,
need
any
implant,
questions for Dr. Oertel? Yes, please continue.
If we need implant, then we actually do open a microsurgical approach.
Okay, okay. So Dr. Nilesh, any question from the viewers, please, to Dr. Oertel?
Dr. Anand Mahuri, who is from Hyderabad, asking that can we use EasyGo system tubular retractor initially with the microscope and slowly transition into the endoscopic at initial stage of learning, initial stage?
Yes, you can. No problem.
Okay.
It's possible. If you're happy with there are 3 different sizes. There's a black, a green, and orange. The black one is about 2.3 centimeters in diameter. If you're happy with the black one, I think it's no problem to use it with a microscope. The orange one, this very small one, is about 1.5 centimeter diameter. The very small one is very difficult to use with the microscope because you need, for the microscope, you need an optical corridor. You need space for your view. This is difficult to achieve with a very small one.
Dr. Oertel, you use... Sir?
Sorry?
Dr. Oertel, you microscope, which endoscopic cautery you are using? Are you using any specific design endoscopic cautery, bipolar cautery, or same?
With the old EasyGo system, with the first generation, you needed this particular bipolar. With the second generation, the workspace is a little bit better, is higher, so 23% more workspace. There you can use a long regular bipolar forceps.
Thank you, sir.
Dr. Oertel, you are using standalone cages, and I can see that there's no locking. I mean, just you press fit, that's it.
Yeah.
Any complication post-op, cage extrusion?
No, but
and
as I said, the thing is, from anterior, we only do cases where we have not a significant narrowing of this space. If you have a very narrow disc space, like only 2-3 millimeters left, and you know that you have to drill the end plates a lot, then we do open approach. We do cage and plate. So this is, so I try to avoid to manipulate at the end plates. I just clean the end plates and then put in the cage. And with this technique, we haven't had any problems so far.
Okay.
But we do a lot. I would say we do 90% of the anterior approaches. We do cage fusion, multiple level, corpectomies. We have a lot of cervical cases here. We do like 200 cervical cases a year.
And your take on
only 10% is done endoscopic of these.
Don't you think cervical disc replacement will be a better option? Yeah. What are your take on cervical disc replacement?
Well, arthroplasty, we have done a lot 10 years ago. Right now, we do more, maybe 4 or 5 per year. Not that many anymore. In our results, we have now long-term follow-up of the cervical arthroplasty. Very, very few remain moving. Most few.
Okay.
We have now 15 years follow-up, and I think it's about 60 or 70 cases. I will be published soon. It's not very good results.
So fusion is back, it means.
Yeah, again back.
Yeah,
correct.
Sir, Can I ask
Thank
one
you.
question to Dr. Oertel?
Yes, Nilesh, go ahead.
Sir, as our learning dates, we used to do a cervical spine surgery from the anterior approach. But if any extra added advantage doing the posterior endoscopic approach over the anterior, have you compared with anterior and posterior series with your own series? Anterior and posterior approach?
You mean if this is a randomized study for anterior or posterior?
Yes, sir. Anything
No,
you
we
have
have not
studied?
done. No, we have a pre-selection of candidates. If there's a significant compression from anterior of this narrowing of the spinal canal, you have a narrow disc space. We come anterior and we do open standard procedure. If you have a neuroforaminal stenosis, particularly if it's from posterior, or you have a central stenosis from posterior, then you can come from posterior. And everything from posterior, which is not long fusion, we do endoscopic. Okay, if we do long fusion fractures in let's see 3-4 level lateral mass screws, then we don't do endoscopic. I don't see any reason to do endoscopic because you have to expose everything. But if it's a non-fusion from posterior, you basically can do everything endoscopic. So it's a selection of candidates. You know, it's not if you have the pathology from
Depends on
posterior.
selection of candidate. So for the posterior, we are in a simplified manner. Posterior surgery we can do for a foraminal stenosis, single level foraminal stenosis. So we can
3
decompress
levels,
the
2. Yeah, well, most of them, as I said, we have evaluated this. You can look the papers up. I think it's World Neurosurgery, 2 papers only on cervical foraminal stenosis. Then we have the one case with the audio you heard is either neurosurgical focus or it's also World Neurosurgery. It's online, the video. It's disc and stenosis. You can just look it up. Use my name and you search for PubMed. If you need a lot of restoration of disc height, if you need a lot of reposition and destruction, to regain cervical lordosis, I think you need a lot of implants, and I think there's not a big role of endoscopy. If you need a circumscribed decompression, endoscopy is a really good technique.
Okay, if any no other question, then we can proceed for this Dr. Rohidas presentation. So today we have a very good, the unique type of webinar where we have the EasyGo and the Destandau technique. Both are made up by the Stars company. And now another visionary of the technique, that endoscopic spine surgery technique of India, Dr. Rohidas. He has also started his career in 2002, I think more than 18 years now. Now we are going to listen Dr. Rohidas of his experience about the endoscopic spine surgery, both again anterior and posterior approach to the cervical spine. Dr. Rohidas, please. Are you ready with your presentation? Till the Dr. Rohidas is ready with his presentation, may I ask one question to Dr. Oertel, please? Dr. Oertel, can I ask a question about your learning curve? What do you want to say
As I
about
said,
the beginners?
if your learning curve is important, if you are experienced with a microsurgical technique and if you have some experience with the endoscope, I think it's less than 10 cases. If you have no experience with one of both, you might need 40, 50 cases because you need to adjust the high magnification. You need to adjust the to get the feeling of the size of the lesion, of the size of the nerve root. You don't have this intraoperative overview you're used to have. So then I think you might need, I would guess, 50 cases. If you have no experience at all, so like no microsurgical technique, no endoscopic technique, well, probably you need 100 or more. It depends on the surgical skills of the individual surgeon. If he is an experienced surgeon, he knows the endoscope, should not be a problem to achieve the same results within 5 cases.
So Dr. Oertel, just you are using the microscope and endoscope both. So can you tell us about the advantages of the endoscope over the microscope, maybe in consideration of the result, maybe immediate result or maybe late result of the surgery?
The biggest advantage of the endoscope, in my opinion, is that you have immediately post-operative less pain. Patients do much better because you have a very small approach, you have less muscle trauma. And you have better cosmetic results. And in the long term, you might have less scarring, but there's no evidence for this. So the biggest difference is in the early post-operative period. In the long term, well, microsurgical decompression will have the same results. But in the short term, you have less muscle trauma. This causes less pain, and this is the biggest advantage using the endoscope. Less blood loss. You don't need blood transfusion in no case. I think this is the big advantage.
Yes, thank you very much. So Rohidas, are you ready with your presentation?
Yes.
Start sharing. Start sharing.
We can go to Dr. Rohidas' presentation. The later on question we can take later on. Some question we receive.
Fine, go ahead.
So you are able to see the screen?
Yes, yes, very well.
Thanks, Dr. Oertel, for the nice explanation of the anterior and posterior approach with EasyGo. Now I'll continue with the Destandau technique, and this is regarding endoscopic cervical approaches for discectomy and cord decompression with Destandau technique. This is the basic principle which I follow. Even those days where we used to do open surgery, microscopic surgery. This is a disc, unilateral herniation and radicular pain because of the root compression. This is a pre-op and this is post-op. This is pre-op and this is post-op. So this is what we are achieving with the endoscopic approach, where we try to preserve the rest of the disc. We go directly down and remove the extruded part of the disc. We don't compromise the whole disc, and we try to preserve the rest of the disc. This is a disc preserving surgery. Now this is a case of a cord compression, a myelopathy. Same approach where we have decompressed it. So this is the anterior approach, Joe's technique, transankle, supine position with slight extension and rotation to the opposite side. Localization we do with the C-arm and the localizing pin. And the incision is as usual through the visceral bundle and the vascular bundle. So we go medial to the vertebral artery through the uncovertable joint, diagonally down towards the root, and if necessary, we go to the cord also for cord decompression. This is one of the slide where the nerve root is compressed. This is the disc. This part of the root from vertebral artery to the dural sac is something around 6 millimeter. And we have to decompress this much part of the root for radiculopathy. And for myelopathy, we can angulate and go to the opposite side, decompress the cord, At the same time, we try to preserve the anterior two-thirds of the vertebral body and the disc. We don't distract the disc or the vertebral bodies. So here we'll have to keep in mind this picture. We go diagonally through the uncovered joint to the root and to the opposite side. This is the cadaver picture. This is the nerve root, which is nicely decompressed, and this is the cord, lateral edge of the cord on the opposite side. This is the cervical localizing pin we use as like the lumbar cervical pin to get the direction of the disc space to approach the disc and the nerve root. We reconfirm the level with the spinal needle, and then we start with the approach. This is the spinal needle through the uncomfortable joint inside the disc space. This is the outer tube, and two retractors are retracting the visceral bundle and the vascular bundle. This is the outer tube and inner tube in place, and this is the drill. We get the entry point here and the direction. So this is the uncomfortable joint. This was my first case with the single chip camera in 2006. And you need a drill. You will not be able to start without a drill. This is the vertebral artery here. And this is the extruded disc. This was the young patient, and it was a traumatic extruded disc with radiculopathy. This is one more case, C4-5, right-sided disc herniation compressing the root. This is the C4-5. You can approach the two levels through the same incision by angulating it. This is the uncomfortable joint. It's a right-sided. This is cranial, caudal, medial, and lateral. We start with the drill and we follow the disc. This is the lateral margin. Vertebral artery is somewhere here. Initially, I used to expose the vertebral artery, but later on, I stopped doing that. We keep a thin layer of bone over the medial vertebral border. This is the disc which we follow, and this is the extruded part of the disc. Dural sac, the root coming out, and then we put a gel foam with methylprednisolone over the exposed nerve root for medical decongestion. This is in the evening. Most of the time we don't put a drain, no collar. He was not able to sleep. This is after about 6 hours after the surgery. And this is the incision. So we follow the disc diagonally. This is the cranial caudal, and this is the disc which we follow. This is the drill with the protection sheath. Then once the medial border of the vertebral artery has exposed, I use this ultrasonic dissector to thin out the bone or remove the bone over the medial part of the vertebral artery to expose the foramen. This is the ultrasonic rasp I use to widen the foraminectomy. You can use a cool knife also. This is less traumatic and less stressful for the surgeon in narrow corridors. When we are not able to distract the vertebral bodies, still we have to go ahead with the foraminectomy. This is the suction. The diameter of the tip of the suction is 4 millimeter. Underneath the suction is the vertebral artery. I have put a Surgicel over that, and this is the extruded part of the disc. This is the dural sac, the nerve root leaving the dural sac, and this is the final exposure. This is the dural sac, nerve root from the dural sac up to the vertebral artery. We are using this technique for single level myelopathy also. This is at C4-5, calcified OPLL. Now the orientation here is a little bit different. This is cranial caudal, this is lateral and medial. We are starting from the right side. This is the uncovertible joint. We start with the drill. We follow the disc. Now here we will follow from lateral to medial. Then this is the cranial vertebral body, this is the caudal, this is the disc, this is lateral and this is medial. And we use the drill to widen the foraminectomy. As this is a myelopathy, we don't have to target the root. We have to decompress the cord. And the foraminectomy is wider as compared it is for the radiculopathy. So this is the disc space, this is the cranial, this is caudal, and these are the osteophytes. So we remove the osteophytes to widen the foraminectomy. Now from the lateral, this is the uncovertible joint, and we use this 2 mm Kerrison punch to remove this osteophyte. The cutting edge of the Kerrison punch is away from the vertebral artery. This is from the caudal vertebra. Then we widen this foraminectomy from lateral to medial to decompress the cord. This is the calcified OPLL. We can use Kerrison punch, we can use drill, we can use ultrasonic rasp or knife. This is hard bone. Always we have to take care of the epidural oozing. Endospine inner tube helps you to support the Kerrison punch or the drill. So we have to remove this calcified OPLL. We can use drill. You have to use the drill sideways, not to and fro. So this is the critical part of the surgery where there is a epidural oozing. We can use bone wax, we can use cottonide and keep it under pressure over there, but you cannot push too much, or you can use flow seal. Use flow seal for a minute, wait for 2-3 minutes and then start the surgery. Here we have used a cottonide here. You need patience when there is an epidural oozing. This is the complete decompression from one lateral end to the other. This is from right to left. And this foraminotomy is something around, this is 10 millimeters by 12 to 14 millimeters. You can appreciate completely decompressed cord. You can put a cottonide. You can put a gel foam soaked with methylprednisolone. And this is the end result. This is a case of a single level myelopathy. To approach the opposite side in the narrow corridor, you have to use the Kerrison punch. Usually it is a 2 millimeter or 1 millimeter Kerrison punch. I use a rotatable Kerrison punch to remove this calcified part of the bone in the opposite narrow corridor. This is the completely free cord. You can confirm by this thing. And this is a thin layer of the posterior layer of the OPLL. You can keep it intact. Otherwise, if you try to remove this, there is too much of epidural oozing. This is one more calcified OPLL at C4-5. And this is the part of the OPLL which we have excised from the lateral end. And then we will be removing it piece by piece with 2 millimeter Kerrison punch. You can appreciate this is the unconvertible joint. We are diagonally inside. This is a 2 millimeter Kerrison punch. This is a case of a myelopathy, but recent extruded disc. She presented with right-sided hemiparesis, young lady, and we tackled it endoscopically through the unconvertible joint. And this, you can see, this is next day in the morning. This is her incision here. No collar. We mobilize the patient after 4 hours, no catheter. So these are the immediate postoperative advantages of the endoscopy. We try to use it for 2 level also. This is a calcified OPLL. And here what we do is something like an oblique corpectomy. We preserve the lateral margins of the bone. This is a cottonide protecting the cord, and I will use ultrasonic rasp. This is the rasp to remove the calcified OPLL. This is more safe than drill or the Kerrison punch. This is the incision. We have done around 77 cases. (20 myelopathies, myeloradiculopathy). This is the clinical myeloradiculopathy. These are the results. 75 excellent results. I had 2 poor results. It was multiple level, 2 level myelopathy, where it was an inadequate decompression. We have to convert it into open and do the fixation. 1 dural puncture, 2 Horner syndromes, and 2 laryngeal nerve neuropraxia because of the traction. We can use the same technique for posterior approach also. This is for the unilateral disc herniation, soft disc, single or 2 level contagious nerve roots we can decompress. So we go do a laminoforaminotomy, decompress the nerve root and find the nerve extruded disc in the axilla or over the shoulder. This was the first case which I did in 2005. Initially I used to localize with the spinal needle. This is the extruded disc in the axilla. This is the axilla, shoulder, and the nerve root, and this is the lateral edge of the dural side. This is the incision. We can use the same incision for 2 levels. This is the cord decompression in the posterior, where I'm undercutting the opposite lamina with the ultrasound. This is at C3-4 level. You can see the bone dust. I have used in 1 or 2 cases where I have performed C3 to C7 hemilaminectomy with 2 incisions, preserving the spinous process, going on the opposite side to decompress the canal. So this cranial incision I have tackled C3 laminectomy, hemilaminectomy, C4 and part of C5, and undercutting of C2 to remove the complete C3. In the caudal incision, part of C5, C6 and C7. I have used this posterior approach in 42 cases. These are the levels. Mostly it is for the 2 levels and cord decompression. 35 excellent results, good in 5, fair in 2. Where there is a cord damage, we have not got any good results. I have used this posterior approach with the endospine for peculiar cases like this is a tumor at C5. This was a neurofibroma. And you can see this is after 6 hours in the recovery. This is the advantage of the endoscopic approach. No catheter, no drain. Thank you. PC? Hello.
Thank you, Rohidas. The nice presentation, both anterior and posterior. We enjoyed a lot. I think there are some questions in my mind. Can I start now?
Let Mohinder finish and then we'll have the question answer.
Okay. So start sharing of the Dr. Mohinder, your presentation. Dr. Mohinder is also another visionary and also the scientist. He has started his MK system, I think, around 2008, and he has invented some of the instrument and technique also, and little different than the Destandau technique. And he is also operating the cervical and lumbar. He is a arthroscopic surgeon, orthopedic surgeon. Also started, I think, 2002 in the India, that is in Chandigarh. Now over to Dr. Mohinder. Unmute, please. Unmute. Mohinder, unmute. Dr. Mohinder, unmute. Unmute yourself.
Yes. Am I audible now?
Yes. Yes. You go ahead.
Okay. Thank you, Dr. PC. So once again, I think cursor is not moving. I think my PowerPoint slide is yeah. I think cervical spine is once again, thank you very much, Health and You, for this educational initiative. I'm sure these educational activities will go a long way to update the knowledge about endoscopic procedures. I think lumbar is a very common part of the spine where endoscopic procedures are commonly talked and discussed, but cervical spine endoscopic procedures are not really that much talked about. So it was very nice of Dr. Rohidas to think about it, and I think Dr. Oertel and Dr. Rohidas has covered beautifully the intricacies of endoscopic surgery of cervical spine, and I'll also be contributing my bit, and I will be talking on endoscopic cervical decompression, splenic myelopathy, and little bit of modification I'll be sharing. I mean, this is what you can say innovation, or you try to contribute to improve patient care. Thank you once again. Greetings
Dr.
from
Rohidas, mute,
Chandigarh
please.
City, beautiful.
Dr. Rohidas, mute, please, mute.
So I strongly subscribe to this philosophy. Medicine is a continuous learning experience, and we should never stop learning and researching new ideas and inventions, innovation for the sake of humanity. So in the background of my presentation, I'll try to put forward few principles which are very important for our colleagues to understand. Currently, endoscopic techniques have been successfully utilized for approaching pathology in the cervical, thoracic, and lumbar spine. Literature support confirms that efficacy of these procedures with respect to less morbidity. The development of retractor system by Destandau and Foley in the late 90s, I think that was the era which heralded the minimal invasive techniques utilizing in the interlaminar window. That is very, very important to understand. So the principles, interlaminar endoscopic techniques mirror those of tubular techniques. Added advantage of improved visualization and more targeted placement due to the manuality of the endoscope. So here the role of endoscope comes in over the microscope, and the ability to manipulate the field of view with optical rotation of the endoscope. This is very, very important to understand that with the endoscope coming in, few advantages are inherent to the endoscopic vision, which are not there in the microscope. And as Dr. Oertel ably said, that 20 years down the line, we may have endoscopy ruling the scenario. So I think principles remain the same as we follow in lumbar spine, like in unilateral biportal lumbar canal decompression, lumbar spine stenosis. It allows the excellent off-angle visualization and the ability to tilt endoscope out into the lateral recess. these principles can be applied for generous decompression of the cord and nerve roots when performing a posterior endoscopic cervical decompression. So I have utilized the principles of lumbar canal decompression in posterior cervical endoscopic spine surgery also. Although there is a learning curve associated with these procedures, endoscopic techniques offer a more powerful and less morbid approach to spinal pathology that ultimately elevates the standard of care when treating our patients. So now I think initially in 2002, when I started spine endoscopy, we had only Destandau system and we had transformanic system. But now I think the market is flooded with the various systems. There is, apart from Destandau technique, we have a EasyGo, we have a arthrospine system. Then last year, I again did little bit of modification of my existing first generation arthrospine system, and it is now arthrospine Duo system. And then we have a UV coming in. We have been talking about UV nowadays. And then we have full endoscopy, true endoscopic PSLD. So I think today a young spine surgeon is more than ever confused how he has to move forward as far as his endoscopic spine practice is concerned. And I think techniques are really evolving at breakneck and fast pace. So the system which I am using, I will briefly share because this is a new system and many of my colleagues are not aware of about this. This is a dual system. This is again patented by Indian patent, and there has been a technical support from a JESCO, which is an implant manufacturing company of India based in Chennai. And this system was launched last year during our MISICON and World Endoscopic Spine Society Conference by Health Minister of our Punjab province. So few salient features. I think this is a system which complements it has the principles of Destandau system and it has a principle of PSLD system also. And if needed, surgeon can switch over to UV also. Now here you see that tip of the scope is coming beyond the confines of the tube. So when you are working so close to the dura and the nerve root, you switch over to a saline medium here and you can see you can work like a PSLD. And it has the same features of the system. You can see the mobility of the system. And you see the beauty is beyond the confines of the tube, you can see the tip of the scope goes ahead and you can virtually see the recess. You can, if you can see the superior, what you call exiting and traversing nerve roots also if you do a little bit of bone work here. I'll try to play this video to share with you. If this, I think video is not going to play, I'll try to, I think, or I go back after some time and then play video. So I'll continue with the presentation. I'll play videos separately in the end. So these are the salient features of the system which I am using. It can be used in a dry mode. So dry mode, it follows the principles of Destandau system. And when it is used in a saline mode, it follows the principle of a PSLD. And if need arises, surgeon can switch over to a UVE mode also, and can be used in a mobile and static mode. The added feature of scope mobility into the canal, into the disc, and it can be rotated clock and anti-clockwise 360 degrees. System is compatible with the 0 and 30 degree scope, easy triangulation, easy learning as familiar posterior approach, and it is an indigenous design that's very, very cost effective also. Indications remain the same like other systems like Destandau or EasyGo system. So my journey of endoscopy began in 2002. In 2010, I was using arthrospine, and from last year, I have been using this Duo system in my clinical practice. This is a simple instrumentation. You can see the instruments remain the same, but some bayonet angle is there in the Carrison punches. And I like to draw your attention to this single cannula arthroscopic sheath. So this is a sheath which is a high flow sheath, which is forward firing, means the fluid comes from the front, and you can lock the scope here. And this is an inflow cannula where you can the fluid goes in. It creates a hydrostatic pressure at the workplace, and which eases makes the surgeon comfortable while doing endoscopic procedure. So this is again instrumentation, simple instrumentation. So now coming back to my topic, I will be talking about a new technique which is called endoscopic spinoplasty. Option today we have is laminectomy, anterior cervical decompression and fusion, and laminoplasty. So to me, being minimal invasive surgeon, endoscopic spinoplasty seems a viable option. And laminectomy, we know the complications of laminectomy, problems of the laminectomy, kyphosis, spinal instability, and laminectomy membrane are the issues which need to be looked into. And ACDF has its own set of problems. It is a lengthy and complicated, immobilizes segments, high mechanical demands on adjacent segment, clinical and radiological deterioration during a follow-up has also been documented in these patients. And talking about expensive laminoplasty, good technique, quick, efficacious and durable, maintains cervical mobility, prevents kyphosis, long-term results surpass that of anterior procedure, but it needs a extensive dissection which we minimal invasive surgeons try to or elected to carry out. And I think endoscopic spinoplasty and cervical spondylitic myelopathy may seem a viable option today. So the best alternative would be endoscopic assisted limited laminectomy and bilateral decompression by unilateral approach, ensuring adequate decompression, thus preserving integrity of contralateral musculature and posterior ligament complex. So my journey of endoscopic spine surgery began somewhere in 2007. 2002, I started doing lumbar spine surgery, endoscopic lumbar spine surgery. And 2007, I gradually gained confidence and started doing cervical spine. I started with simple discs. And endoscopic bilateral hemilaminectomies I was doing earlier since I think I can't make out 2009 or 10. And endoscopic spinoplasty I started doing in year 2017. So I'll briefly touch upon what is endoscopic spinal laminoplasty. If you search the literature, you will not find any article on these endoscopic spinoplasty. This is the article which I could lay hands on. This is related in the lumbar area, and same principles I use in the cervical spine. So this was the article which was written by our very senior teacher, Professor S.M. Tulli, and they had 610 patients. I'll go back again. You can see here they try to preserve the posterior spinous processes, interspinous and supraspinous ligament. They do a bilateral hemilaminectomies here and suture this posterior tension, posterior structures back, thus preserving the stability of the spine. This is open spine surgery. And now this is a paper which motivated me to do this kind of procedure in the cervical spine. And it is a very good paper. And they had a follow-up 3 to 10 years. I mean, not a small years follow-up, 10 years follow-up. And they observed that there was no significant difference in the sagittal alignment as well as anterior translation. The spine was as good as stable. So there was no need to instrument the spine. So the indications for endoscopic spinoplasty, ideal indications are OPLL, it could be continuous or mixed OPLL, multisegmental cervical stenosis. Ligamentum flavum hypertrophy is, in this case, it is not recommended. And contraindications are focal anterior compression, established absolute kyphosis, isolated radiculopathy, and spinal instability, where this kind of procedure should be avoided. So now I'll try to share with you the pre-op MRI sagittal. You can see continuous OPLL from right from C2, C3, C4 reaching up to the upper vertebra or upper vertebral margin of the C5, and this is the axial cuts. You can see how the bony outgrowths are there, osteophytic growths are there, occupying most of the canal. Patient positioning. I mean, patient is prone. Earlier I was flexing the neck, but nowadays I keep neck in the neutral position and try to save the eyes by providing a pressure over the, we put the face down over the ring, and shoulders are pulled down to have a good exposure. Otherwise at times in area of C5, 6, C6, 7, you find it difficult to see those areas because shoulders are come in a way. So patient is put prone, 8 to 10 millimeter paramedian skin and facial incision over the localized level is given. Then sequential dilators, only 2 dilators are used, 5 and 10 millimeter, followed by sliding of arthrospine tube over 10 mm dilators. I think now I go back and play a video from my here. So first I'll try to tell you what exactly I want to share. You can see here. So the scope sheath moves much out of the tube. Tube stays at the interlaminar window, and you can virtually see the opposite side. So here, surgeon has to switch over to a saline mode. You can't really work here in a air or a dry medium. Achha, now I'll try to tell exactly on spinoplasty on a spine model what exactly I am doing. You can see here. Oh, PC, my voice is visible, or I should speak? Shall I speak, or you can hear my voice of the computer?
Yeah, clear.
You have to speak. You have to speak.
Yeah.
Achha, I have to speak.
Yeah, it is
Okay.
clear.
So
The
now
voice
you
is
can
not visible.
see.
You have to speak. Voice is not audible. You have to speak.
Okay,
You speak.
I'll
Continue.
speak in the.
Continue.
Okay, I'll speak in the next video then. So here is a now operative technique. So needle marking at the spinolaminar junction or the facet. So skin and facial incision, as Oertel was telling, 10 millimeter. And then this is a special dilator which has got a Cobb's type of a tip, Cobb's spine elevator, and try to erase the muscle up to the level of the facet. Then tube is slid over this dilator, and dilator is withdrawn. So for dry endoscopy, we are using a specially designed working insert. So you can see 3 ports on top, one for the scope, one for the suction canal. So scope sheath is gone in there. So you can see how the scope can rotate 360 degrees, because this is a 30-degree scope. So whichever area you want to work, you can rotate the scope to that area. So when you are working in a dry mode, the principles remain same as Dr. Destandau has advocated. And when you are switching over to PSLD or the saline mode, then you switch over to another working insert which has got only 2 ports. These are 2 5 mm with 5 mm holes. So saline goes in through the sheath of the scope, similarly like we do arthroscopy of the joints. Scope is locked. So, and it is an open system. Fluid comes out from the second hole, and this is how the surgeon uses the working instrument. So fluid is doing the job of retraction and control of a hemostasis. So this is was the video just to make you understand what exactly spinoplasty is. Now I'll share with you the intro video. So this is how you can see the inside picture. The nibbling of the part of the lamina. Either you use a 2 mm or a 3 mm Carrison punch. When you are very close to the surgical target, you have to switch over to 2 mm Carrison punch, because the diameter of the lower tube is very, very narrow here. In contrast to the Destandau system or in EasyGo, you have a choice. You can switch over to a bigger dilators. So this is the first step, doing a laminotomy and hemilaminectomy. Then we work bit by bit to remove the flavum and the lamina of ipsilateral side or the side of the surgeon. As you're seeing here, the cord has been nicely decompressed in midline and on the one side. So good magnification, good illumination. And after you are done a work on your side, then you can switch over to contralateral side like this. So this is how over the top you try to work on the opposite side. And here when you are working at there, you have to switch over to a thinner suction here. There are two set of suctions which surgeon has to use. So this is doing the decompression on the opposite side and then final decompression. Yeah. So this is a final decompression, and you can see that when I will be withdrawing my scope, you can see the floating spinous processes here, which are left. Now it is better, and you can see the floating spinous process here. How do I exit this? So now coming back to my presentation. So now this is a post of MRI, sagittal you can see, and good opening of the space. You can see how the cord is thoroughly decompressed. And these are the post of X-rays of the patient. You can see the floating C3 and C4 spinous process. Here I did an undercutting of the C2 process. I think this problem I discussed with Dr. Rohidas about 6 or 7 years back, when he used to say, if we leave the spinal processes like this, they may cause impingement of the cord. But somehow very small series, I have not come across that problem. And this is a small scar over the neck, posterior part, nape of the neck. So in my journey of spine endoscopy since 2002, I have done around 65 cases of cervical canal decompression. And as per Nurex grade, the results have been pretty satisfying, but these patients, they rarely become normal, but they do improve in degrees. That's very, very important for us to understand. And I have done endoscopic bilateral hemilaminectomy 55. Here what I was doing, I was first opening one side, entering one side, and doing moving a hemilaminectomy on one side. Then I was doing a entering on opposite side and doing a laminectomy on that side and leaving the midline structures intact. And now I am able to achieve the same job without opening the opposite side and through the same side. But here I have to osteotomize the spinous processes. And last year only, I think 2018, I started doing this procedure. And I think my patients are doing pretty well. I mean, without any problems in the post-operative period, and their neurological recovery has also been good. So just a word about learning these techniques. This is very, very important. Learning these techniques, MIS techniques, are hard, and mastering these techniques is even harder. But I think we should take our time when we are learning to adequate decompress first. Keep going to as many MIS courses as possible. As you can see here in 2002, when I visited Dr. Destandau, on third or fourth day, he put me to practice on a spine model. You can see here, this is a 2002, November 2002 picture. And again, to minimize learning curve, you must visit a surgeon who is routinely doing these procedures, and then attend few workshops, cadaveric workshop on hands-on models, and then finally do first procedure in your own theater. This is a teaching slide from a Joymax and very relevant as far as learning of these techniques is concerned. And to summarize, endoscopic spinoplasty retains median structures, contralateral musculature with least disturbance of kinematics, mobility, stability, and lordosis of the cervical spine. A need of implants is minimized. Well-designed clinical trials to show the effectiveness and long-term outcome of these surgical pieces, I think, is warranted. And my final thoughts, as technological innovation continues to facilitate reproducible surgical technique and expand the indication for use, we believe that endoscopic spine surgical techniques will provide surgeons with a more powerful and less morbid approach to spine pathology that ultimately elevate the standard of care when treating our patients. Thank you very much.
So thank you, Dr. Mahinder. I think that is very good.
I am done with my presentation.
Yes, yes. Thank you very much. Thank you very much. Now, yes. So I have some of the questions in my mind. Can I start, Dr. Nilesh?
Yes, sir.
Are
You start
here,
your
Dr.
question, then
Nilesh?
we'll take the audience question. Later on, we'll
Okay,
take
so-
audience question.
Okay, Dr. Oertel is also here. I got the message that Dr. Rohidas is presented his Destandau technique. I think he is only both anterior and posterior, and from the anterior he is removing only 30 to 40% of the disc and leaving the 60 to 70% of the disc, and no need to any fixation device. He is not using any fixation device. And I think Dr. Mahinder is also doing almost the same thing. I have a question to Dr. Rohidas. If you are using the both the anterior and posterior approach for the discectomy a single level, and what is the principle of approach that in which case you prefer to use the discectomy for the discectomy from the anterior approach, and which from the posterior approach? Dr. Rohidas, unmute.
Basically, I started with posterior endoscopy first, and then that was in 2005, and 2006 I started with the anterior endoscopic technique. A soft disc without any osteophyte, I'll approach posteriorly. A disc with osteophyte in the foramen, I'll approach anteriorly, so that the nerve root decompression is quite adequate. Now, in cases of myelopathy, the results are not that good, not that satisfactory, because the cord is damaged. The endoscopic results are very good in compressive radiculopathies. The patient is very happy, immediate pain relief, and the endoscopic advantages of less trauma to the muscle, they appreciate it very well. 2-level nerve root decompression, I'll go for posteriorly. C7T1, I'll go posteriorly, not anteriorly. So these are the things which I follow in my practice.
I think it is very clear now. One thing I just wanted to know from you, what is that flow seal you are using?
Flow seal is a chemical. It is something like a coagulant. You have to prepare it and put it inside the operative area so that it aggravates the coagulation of the epidural oozing. It helps a lot. And after putting that, you can wait for about 2-3 minutes and then start working again. Rather than cauterizing the epidural veins in very narrow corridors, flow seal, I think it's very useful. But I have used it in 1 or 2 cases only.
Yes. Okay. So another question I have that Dr. Oertel is using the serial dilators, and Dr. Mahinder is also using the dilators. I think 2 dilators, and you are using not any dilators. So are you facing any problem for without using the dilators? You are just ducking the instrument. Are you facing to remove the lot of muscles or fascia or soft tissue?
No, it is question, we separate the muscle and then we put the outer tube. It's the same principle. You can use serial dilators to dilate the muscle. We separate the muscle and then we put the outer tube, which is the single tube. Basically, it is not different at all.
From audience, we can take the 2 question on this same topic.
Yes, please. Go ahead, Nilesh.
audience has there are two audience. One Dr. Sagar from Mumbai. He is asking the chance of injury to a vital structure in endoscopic anterior approach. And one more question similar in this kind of things. Dr. Satish from Bangalore asking that for C6, C7 level, do you use left side? Any increases in the recurrent nerve palsy as it is while using the dilators. We can't see nerve during this dilatation. It is blindly procedure.
Dr. Oertel?
Yeah, Dr. Oertel, you have to unmute.
Yeah.
Yes. Yes.
Okay. Well, the selection of candidates, how to use the technique. This is I think the key issue. This is the key issue: how to proceed with the technique. And well, it depends on your personal preference. You can come from anterior and posterior. You can you use a lot of techniques to achieve good results, but it depends a little bit on your personal experience and your personal preference and your personal skills, which technique to use and how to achieve sufficient decompression and hemostasis. It's not that you can really find it, you know, like a general rule, you have to do it this way if you have this. And well, I think this is the key issue. The key issue is that you have to do these cases on a regular basis, not one case a month or so, but on a regular basis. And then I think this is the key issue to achieve results. And you have to be honest with your own results. And then you can see whether this approach is and the technique is suitable for you or not.
About this recurrent laryngeal nerve, the same risk is there with the open surgery.
No.
Here we go through the medially it is the visceral bundle, trachea and esophagus. Laterally it is the carotid. So we have to do a finger dissection. Only the incision is small. The dissection remains same. The traction, because of the retractors which we put laterally around the tube, it can have a traction over the laryngeal nerve. And in two of my patients, I had the laryngeal nerve, this thing, and it recovered with the steroids.
Sir,
Well,
which which catheter we are using?
These are clawed retractors.
But usually you expose the nerve.
Hello.
These are the open cohorts retractor or any specific
Open, without the handle. Only blades.
Only blades we can use that for use for open surgery.
Yes. Oertel was talking something.
No. The thing with the nerve is, well, we select, for example, to come from the right side if we want to approach the contralateral frame in an open approach. The same thing is to come from the left side if you want to approach laryngeal nerve. The recurrent laryngeal nerve injury, if you do a step-by-step exposure, is very rare, and it's definitely not higher with the endoscope. I don't recall that we had any injury in the last time, even in the open cases. But frequently you see the nerve, and then you have to expose the nerve. You can push the nerve aside, then you have a transient paresis. But permanent paresis, you have to cut the nerve. You will notice this usually.
Any other question, Dr. Nilesh?
Nilesh, any question? Nilesh?
Yeah, I think yes.
Sir, there are a few more questions on vertebral distraction. I will give one by one. You can answer in one single. So,
Yes.
Dr. Raghavendra from Manipal is asking, do you distract the vertebral bodies while inserting the cage by any means? Then Dr. Shankar Athole, Athole sir from Mumbai, is asking that to Dr. Professor Oertel, in which cases you are putting the cage, and Dr. Dr. Amit Kulkarni from Bangalore is asking, how do you decompress the exiting root, now root, before placing the cage? So these three questions we can answer in one.
Address at the same time. Yeah.
We'll start with Dr.
Because it's a similar question, you can address at the same time. Dr. Oertel, please. Unmute.
Well, to be honest, can you just briefly repeat the question? I had a bad internet connection right now.
Nilesh, repeat it.
I can summarize. Yeah, there's three questions they have asked. One is are you distracting the disk space for the putting the cage? And the second question is what is your indication to put the cage? I think third question is also related to that, how to protect your nerve while putting the cage.
Okay. Well, we don't distract this space to put in the cage. We only put in the cage with this technique. We only use the cage which fits really the remaining disk space. Then the second is we don't protect anything because we will carefully put in the cage just slightly without much force. So you cannot introduce the cage too far posterior. And I think with this, it's quite easy to put in a cage. And it has to be small, so then the cage fits the widest retractors, the widest speculum, widest tube. You can also do it open with the Langenbeck retractors. Then you can actually distract this space a little bit, but it's not, I mean, if there's a significant narrowing of the disk space, I would not go without Caspar retraction. So then it's rather an open procedure. And actually, we do almost always discectomy. The case Dr. Rohidas presented, probably we would do from posterior. If it's mediolateral interforaminal, we come rather from posterior than from anterior. If you have a significant narrowing of the old spinal canal, then we come from anterior. And in this case, then we do a complete discectomy and then we put in a cage. So there's basically in our hands no anterior approach without a cage.
I think it's very clear now. Yes, go ahead, Nilesh.
Dr. Shailendra Markand from Ahmednagar is asking that, have you used any anterior cervical plating or only a standalone cage is required? Can we do without implant?
Without implant at all, as I said, this is basically the same topic. We rarely do partial discectomy. We mainly do posterior decompression or complete decompression of the spinal canal. Then we come from anterior, and then we always put in a cage. But it's possible. It's published frequently. Dr. Rohidas has shown you. But in our hands, the partial discectomy, I think, yeah, we just don't do. I'm very happy with the complete discectomy with the long-term results. You can look this up if you want to. We have published 4 or 5 papers on this with a 20 years follow-up from anatomy and fusion. So we have to compare to this. And then if you can come from posterior, I think that's fine. If you can come from anterior, we do come.
Okay, next.
Sir, next question we can go. To Dr. Rohidas, sir. He is Dr. Anand Babu from Hyderabad, and he is asking to Dr. Rohidas, sir, do you have any special retractor on either side of a mobile outer tube Destandau system which is going to anterior cervical approach? So
No,
sir has already answered that plating. We have,
both the retractors are from the Cloward set. These are
and one
used to retract the visceral bundle and the vascular bundle. Medially, it is the esophagus and trachea, and laterally, it is the carotid sheath. The carotid we retract laterally.
and similar type of question Dr. Vijay asking from Jaipur. He is asking you, sir, how will you reach up to the oncovertebral joint by applying retractor or like a lumbar region by muscle splitting?
No, it is unconvertible joint. You have to do after taking the incision, dissect the platysma, and then with the finger dissect in between the tracheoesophagus medially and laterally the carotid sheath. With the finger, you have to reach to the longest coli, and then we put the retractor, and then we cut the longest coli, and laterally we expose the unconvertible joint. And while cutting that, you have to take care of the sympathetic chain.
Just Dr. Satish
Any
from
other
Bangalore
question?
he is asking that any vertebral artery injury has Dr. Rohidas sir or any other members, any other panelist who has encountered and how to handle it?
No, the only thing is that initially I was very obsessed with exposure of the vertebral artery. That's why I have mentioned one complication of pseudo aneurysm of vertebral artery. That was not at my place, but where I did one demonstration at Jabalpur. They noticed it. So this can happen. The epidural oozing from the venous oozing from the vertebral artery plexus is quite cumbersome. You cannot cauterize. That's why when it is exposed, I put a Surgicel over that. It controls the bleeding. Rather than cauterizing it and going ahead with it, it is better to use Surgicel. And nowadays we don't expose it completely.
Any other panelists have some experience, so they can share with us.
Dr. Oertel, about vertebral artery.
No, well, I have experienced vertebral artery injury twice, but only in open cases. In complete corpectomy, multiple levels, where you have to resect everything. There I had a vertebral artery bleeding. We were able to reconstruct the vertebral artery in both cases with a taco seal and some subcutaneous fat, and then they did not develop any aneurysm. But in the endoscopic cases, usually it's not that an issue, because you have a very high magnification, and you're very focused, very localized on the decompression of the nerve root. So I only have experience with this in the open cases.
So, sir, can I go to next question to Dr. Oertel? Dr. Shankar Athavale from Mumbai asking to Dr. Oertel that are you doing a lateral mass screw fixation with endoscopic or and this question goes to Dr. Mohinder sir also. So both of you can answer.
Unmute,
Unmute, Dr. Oertel.
You have to unmute.
Yeah, sorry. Yeah. We do a lot of endoscopic decompression, and we do a lot of lateral mass screwing, but we don't combine these. The lateral mass screw systems, which are available at least in Germany, they are not MIS systems. They are all open systems right now, and it does not make sense to do endoscopic decompression because you have such a wide exposure if you want to do an open lateral mass screw. So we don't combine these two techniques. But we do like 30 to 40 cases per year lateral mass screws.
Dr. Mohinder sir, can you add your comment that laminoplasty with
as far as degenerative spine is concerned, if you have not caused any destabilization of the spine, I think lateral mass plating is not required. And I think I did my last lateral mass plating somewhere way back in 2005-2006. I think my open spine surgery is now maybe at 10%. Here I have to fix a fracture of the vertebra or fracture spine. Then only I open the spine. My all degenerative spine surgeries are all endoscopic nowadays. And I think, as Otto said, that I rarely do little mass after my endoscopic spine procedures.
Sir, one more question coming from the audience. Dr. Shrikant from Mumbai. He is asking a question to Dr. Rohidas, sir. He is asking that your approach is a little bit lateral. Do you have any vertebral artery injury? That same question, vertebral artery, but the approach is little.
Initially, I was trying to expose the vertebral artery in between the two transverse processes, see the medial margin of the vertebral artery, and then go laterally, then go medially. But afterwards, I have stopped doing that. I go inside the disc, come laterally little bit till I see the nerve root and the bone over the medial margin of the vertebral artery so as to protect it from injury. I use ultrasonic bone dissectors also to protect the vertebral artery injury because of the drill and the Kerrison punch. So try to be as safe as possible.
Sir, right now all the questions were taken up. Dr. PCD, sir, you have any question?
Yeah, I have a question to all the panelists here that as we have discussed with Dr. Oertel, the initial result is very good. Maybe in the long run, the result is the same in comparison to the microscope. As at present, we know everybody is the gold standard is the microscope, and we endoscopy people are competing with the microscope now. And I think the early result surpasses sometimes the endoscopic result surpasses the microscope, but long term it is not. But what I was to enter, I just wanted to know from the panelist about the complication. As about the complication, can you just elaborate what are the result from the complication wise from the microscope and then comparison to the endoscope? Dr. Oertel, please.
Or in other way, we can ask Dr. Oertel. He is a senior person with a lot of experience. What is going to be the future of endoscopy?
Well, I think right now when there's a talk about evidence in spine surgery, and well, I think there will not be evidence that the endoscope or MIS procedures provide superior results in the long term than the standard microscopic procedures. But in the short term, if you look at the data right now and all the randomized studies, in the short term, it's very obvious that we have less blood loss, faster recovery, less surgical time, less postoperative pain, less need for postoperative pain medication, earlier return to work when we use endoscopic and MIS procedures. And I think when you put all this together, same long-term results, same complication rate, same early success rate, but less post-op pain, less blood loss, earlier return to work, then when you put this together, there's evidence that the MIS endoscopic procedures provide superior results. So this is the first thing. And in the long term, we will not, I doubt that you have long-term results much better than microscope, because we have already 95% success rate. And, you know, this is very difficult to have evidence that you have 96 or 97% success rate compared with a microscope. So I think when you put all the data together, there is evidence endoscope MIS technique is superior to open and microscopic, but it's rather in the early postoperative period, not on the long term. Second thing is, what is the future? Oh, I'm very sure that the more digital imaging we have, the bigger will be the role of any exoscopic, endoscopic procedures. Maybe it's not that it will, most of the techniques don't look like an endoscope. It looks like it now, but maybe in 10 years from now, we have a different tool, which is then called, I don't know, whatever kind of endoscope. but I'm sure that we will have a change to more minimally invasive techniques and digital imaging. I'm very convinced about this.
What about the patient demand in future?
Well, I think the patient demand is one thing. It's very rare if a patient approaches me and says he wants an endoscopic procedure, and I'm convinced that this is not the best procedure for the patient. It's very rare that they leave. This is the key step. The first step is you have a good patient-doctor relationship. And if the patient does not trust the doctor and the doctor says, well, I would do endoscopic, I would do open. If this is not the case, don't continue. Okay, if a patient insists on endoscopic, you think endoscopic is not the best treatment for this case, and don't continue. You should send the patient somewhere else. So there's a significant patient demand, but I think right now it's already very high. It's basically any informed patient asks for MIS. So
Yes.
it will not be much more than now because it's maximum already.
Okay. So it's a good message. So people are demanding nowadays this endoscopic surgery. This any other question?
Yes, sir. Dr. Sandeep Saraf from Visakhapatnam, he is asking how to go about endoscopically in the revision cases.
Unmute. Dr. Oertel, unmute.
Sorry.
Yes.
With revision cases is very difficult because in revision case, first thing what is a real revision? Revision means that you do a recurrent disc or whatever procedure exactly at the same spot. Well, this is quite rare. The thing is, if you, for example, what is the most frequent revision case we have? The most frequent revision case we have is that there was insufficient decompression in the first place. So then if you go in again and let's see that the nerve root was not exposed accurately, this can easily be done with the endoscope again. But it was a good if it was a good procedure and a decompression of everything and there's a lot of scarring, then you have to think yourself if this is a really good case for revision. So revision is possible as long as the reason why the patient comes back is obvious. Okay, if you have no bony structures, no orientation intraoperatively, then I would not do it again with the endoscope. If there's any doubt, very difficult thing, you have to expose everything, you don't know exactly where is going to be the problem. You have to really relieve all the scars, dura, nerve root, everything, then I would probably do it open.
Okay. Yes, nice. Any other question?
So can I take one question?
Yeah.
So
Dr.
can I take one question?
I think Dr. Mahendra want to add here something on the revision or any recurrences.
I think in cervical region, I have not come across, although I have a very small series of cervical discs, I have not come across even one recurrence. But in one of my patients, I ended up doing a inadequate posterior cervical canal decompression. When post-op he didn't recover, I did his repeat MRI and I had to go in. But that was one level I had skipped. I missed one level of decompression. So again, that was a virgin area. So I didn't face any problem as far as scar was concerned. And this was done in about, say, within 2 weeks of first surgery.
Okay.
Rohidas
Okay,
can share if he has come across
ahead.
any recurrent disc in cervical region. Rohidas has disappeared.
Yeah, I think his internet connection is out.
Sorry,
He's
anterior.
reconnecting, I think. Anyway, yeah. Nilesh, go ahead.
Yes, sir, one question from my side. By posteriorly, if we are doing inadequate decompression, then can we go to anterior next setting to decompress completely and putting some cage or like that? If we feel the inadequate decompression from the posterior side, then we can take anterior with endoscopic or open. That is the one question.
Oh, you can do this. You can do this, but it's usually the thing is if you have missed the decompression, insufficient decompression from posterior, then it's an option to come again from posterior, or you can come from anterior. Both is possible. I would not go from anterior if the lesion is mainly posterior. If the compression is mainly anterior, you have done from posterior, you were not successful, then probably I would come from anterior. So you have to look at the individual case. What is the reason why this was an unsuccessful surgery?
That's why in a implant or a fixation we can consider for anterior because already we did a posterior and did some laminectomy and facetectomy. So can we go to anterior with endoscopic without fixation or anteriorly with fixation? That is the one thing I'm asking.
So if you do facetectomy from posterior and then you come from anterior, do discectomy and cut the ligaments, I would do fusion. I would almost always do fusion. If you do the same level from anterior and posterior, I don't think that it's good.
Sorry, my internet connection was not there.
Yeah.
Sir, one question for you, sir. And if you are able to hear our previous conversation, can you add your own comments, sir? Posteriorly, if inadequate, we feel inadequate, then we same level we we'll go to anterior with fixation or without fixation.
I do all these surgeries without fixation. I do all the surgeries without fixation, and those who need fixation, I send it to others.
Sir, this is the one question from Dr. Vijay from Jaipur. He is asking to you, sir, how you cut the annulus or capsule if ossified, ligament is ossified?
In the cervical.
Anterior cervical, how you cut the annulus?
We go from lateral, from the uncovertable joint, we burr out the vertebral body's end plates, and then we try to separate that calcified part of the OPLL. We mobilize it little anteriorly and then try to cut it with the 1 mm or 2 mm Kerrison punch. It's a very risky thing. It's not that easy. So I'm not happy with the results of the myelopathy.
Well, in myelopathy, if you have OPLL or something, we always do corpectomy. This
is But what we have done is only single level,
Well, there's another aspect we have not talked about. If you have severe myelopathy, even if you do very good surgery, do sufficient decompression, patient might further deteriorate.
That's why I usually don't do surgery for myelopathy.
Yeah, so we do a lot of myelopathy. So what we always try we do maximum decompression. So that there's no doubt that you cannot do anything, that there's no remnant compression. So I think myelopathy is not a good case for decompression, endoscopic decompression, because you want to see that there is really a lot of space. But then even if the patient further deteriorates, you know that you cannot do anything for him. If you do endoscopic decompression and you see there's some tightness, you always discuss, well, is this because it was insufficient decompression? Although you know it was fine, but the image might not really reveal this. So I think if you have severe myelopathy, do as maximum decompression as possible.
And there is already cord damage. We try to do
Yeah, they don't recover. They might further deteriorate, although you
we
decompress
do
everything.
tractography, explain to the patient and relatives that look, this much cord is damaged. Still, they are unhappy. Patient with radicular pain, unable to sleep, unable to sit, they are very happy after the surgery.
Then you send to all the patient to Dr. Mohinder. He's taking up.
Myelopathy patients usually, I avoid doing myelopathy patients because I don't want to spoil my good night's sleep. These patients, in spite of their good counseling pre-operative, these patients still in the after procedure, they keep on coming to your OPD and they keep on telling you that they have not recovered well, they have not recovered as they were expecting. But I think I am very reluctant to take up myelopathy cases, bad cases, poor cord changes. I avoid them taking up. I send them to a teaching institute. I mean, I don't want in my private practice that I'll take up these cases. Yes, in the beginning, I burned my fingers. I did do these cases and recovery was not very good. I mean, these cases are double-edged sword. Some cases do well, some cases they don't do well. So I really bad patients who is coming to me on a wheelchair with cord changes, I usually tell them to go to a big hospital or a teaching institute where these kind of cases they are taking up routinely.
Any other question, Nilesh?
Sir, this question from Dr. Srikanth from Mumbai. And he is asking that in spite of adequate dissection of some muscles remain in the tubular retractor space, how do you manage this muscle which occupies this tubular space?
Total.
Well, what is it that you have muscle tissue in the tube? Is that the question?
Yes, yes.
Okay, well, this is because then you did not plan the approach appropriately. If you really have an angulated tube, that you have a lot of connective muscle tissue in your tube, you have to do a different skin incision. There's no way to continue. You have to remove so much muscle tissue. So you really have to have a straight approach, that the tube is in contact with the lamina and the facet, clear contact, straight down, and then you don't have any problem with the muscle tissue. You have some remnant, but it's 2-3 millimeters, that's it. If you have a lot of muscle tissue coming in, then probably the angulation of the tube is too much, and then there's almost no way to continue.
It's fine, Nilesh. Any other question?
Yes, sir. This question from Shankar Athavale from Mumbai. He is asking that to Dr. Rohidas, sir, are you doing a dorsolateral vertebral removal of the wide foraminotomy?
Yeah, Rohidas, unmute. Rohidas, unmute. Yes.
Sir, this question for you, Dr. Athavale from Mumbai asking that, are you doing a dorsolateral vertebral removal to do the wide foraminotomy?
No.
Sir, are you able to hear my question? He's asking dorsolateral vertebral body removal to do a wide foraminotomy.
In cervical?
Cervical. That is the question he is coming with.
No. In cases I have tried oblique corpectomy, where I have removed the posterior 1/3 of the body to decompress the cord. This is for the cord decompression, not for the foraminotomy.
Yes. So we have done with almost all the questions.
Very good. Okay.
Dr. P.C. Day, sir, you have some inputs or any question?
Otherwise, we'll
No. I think it is already time. It is already time. Is enough question we've discussed. I think I like to thanks all the faculty or participants here, I think there was a very good discussion. We have seen today all the three variety of that EasyGo technique from Dr. Oertel. He is the master of the technique, how he has demonstrated the posterior and anterior approach to all the variety of cases, and then the Destandau technique, Dr. Rohidas, for both anterior and posterior. And there is a new technique developed by Dr. Mahinder Kaushal. He is using very small incision in comparison to these two technique, and so he is using only 10 millimeter incision. Though I think the similar variety, the approach is the same, though he is experiencing a little less, but I think it is all are evolving. What we got the message from all the today's discussion, that this endoscopic technique is, I think the indication is expanding every day, day by day. I think the instrumentation is also evolving, and then the people that patient is demanding, that the patient demands this the endoscopic technique surgery. So no way you cannot escape that. The surgeon cannot escape this technique. So this is the future in comparison to the open technique and microscopic technique. This is the message we have given today, and I think by this we just maybe Deepak, you want to conclude?
Yes. On behalf of Health and You, I wish to thank our international guest faculty, Dr. Oertel, and on behalf of all the doctors, 1,009 doctors logged in today. And on behalf of all of them, I would like to thank Dr. Oertel to join us in this webinar and display his EasyGo technique, which he has pioneered himself. And this he has done in spite of his hospital busy in COVID-19 patients. So we really thank Dr. Oertel for your time and for display of your technique. I would like to thank Dr. Rohidas to put together this fantastic webinar series of 3 parts, displaying the technique, the demonstration, the discussion, and the narration that went on with this. Ably supported by Dr. Mahinder Kaushal with his own techniques, Dr. P.C. Day with his demonstration of technique and fantastic coordination, his own questions added to the knowledge. And I would also like to thank Dr. Mukul, who joined us in the part 2 of this webinar. Ably coordinated with question and answers by Dr. Nilesh. Thank you very much, Dr. Nilesh, for coordinating the entire session. We are ending this fantastic series of 3 parts of the webinar today. And thank you, Dr. Rohidas, for putting this all together in a fantastic manner. We got record logins, almost average 800 plus, and today was a record with 1,009 logins, doctors coming on their own to attend this session. This also shows about the popularity of all the faculty as a teacher, popularity that is growing of Destandau techniques, and the EasyGo technique that is now displayed by Dr. Oertel. On behalf of Health and You and DigiNeuro platform, I would like to thank all the audience who has come forward to log in for these sessions. All the 3 parts of the webinar, taking out their valuable time. I'm sure they must have got benefited by this webinar tremendously. And we also thank them to take care of Indians in this COVID-19 crisis. Thank you very much. Stay safe, stay healthy. We are still in the lockdown period. And on behalf of Health and You, I am Deepak Naik, signing off. Health and You, always together with you. Thank you so much. So nice.